Welcome. We might get started because everyone's time is precious. So thank you for joining us for this session on optimising the management of common corneal conditions. What do corneal specialists tell their patients? Part 1. And first off, I would like to invite Associate Professor Elaine Chung from Melbourne, who'll be talking on, is there anything new in pterygium surgery? She works with the Royal Melbourne Hospital.
So what's new in pterygium surgery? When you think about pterygium, does your heart sink when you see a thick, juicy, bi-headed pterygium? And then you think, are there better ways to remove a pterygium? How do I reduce the recurrence rate in primary and also redo pterygium? When should I excise the pterygium? And do I really have to remove the pterygium before cataract surgery? Now, should I insert a toric intraocular lens if there's a pterygium? And when should I insert a toric lens after pterygium surgery? So these are the questions. So when should I excise pterygium? So a lot of the times, 50% of the time, people actually excise the pterygium for cosmetic reasons. And obviously because if it's inflamed or symptomatic, if it's encroaching or at the visual axis, if it causes a lot of significant astigmatism, or it's affecting contact lens wear, or it's affecting double vision, causing double vision and affecting eye movement, and also before cataract surgery. So do I really have to remove the pterygium before cataract surgery? Yes, if you're worried about the above issues and the cosmesis, the inflammation and the astigmatism, but no, if it's extremely small, it's not worsening over the last 10 years, it's not inflamed, not symptomatic, not encroaching at all onto the visual axis, no significant astigmatism, and also limited visual potential in that eye. So when should I insert a toric intraocular lens? So after pterygium excision, you typically wait for about 3 months for the cornea to stabilize, and then perform an A scan, and you can put in a toric lens as appropriate. Now, the most common complication is pterygium recurrence, and this typically occurs in the first year following excision. So Donald Tan is one of the invited speakers from Singapore, and I had the privilege of being his fellow for 2 years in Singapore. He came out with a pterygium grading system. Essentially, all it does is to look at how opaque the pterygium is. So the thinner the pterygium is, it's grade 1, which is atrophic, where you can see through the pterygium and see the episcleral vessels, versus grade 3, which is very fleshy and very thick, where there's a lot of obscuration of the underlying episcleral vessels. It just means that it's more difficult to remove and higher chance of recurrence. So there's actually a huge variation in clinical practice when it comes to pterygium surgery. So this is published in Corneal, and it interviewed it's a survey of about 120 corneal specialists looking at the practice preference in primary pterygium surgery. So most of them do conjunctival autograft surgery along with excision. They do not use any adjuvant, and 61% actually use fibrin glue, and reported rates of recurrence is less than 5%. The preferred treatment for possible early recurrence is actually just increasing the steroids. So is there a better way to remove pterygium? So the main points to remove the pterygium is a very large tenonectomy. So you got to go superiorly, inferiorly, and all the way up to the caruncle. Also take a very large conjunctival autograft. So when you take the conjunctival autograft, be very careful to only take the conjunctiva and leave the tenons behind. So having a really, really thin layer is important, and it needs to be large enough to cover the defect without any tension. So this is actually extrapolated from Laurie Hurst's paper of the perfect technique, where there's actually extensive, extended removal of the tenons and also extended conjunctival transplant. So in his case series, there's only one recurrence in 1,000 cases of pterygium that he's done. The other way to a better way to remove a pterygium is also to use fibrin glue, which is a sutureless method, okay? What it does is that it creates less post-op inflammation. There's less pain. The patient is a lot more comfortable. It is also way faster. If you have the suture of 14 by 14 conjunctival autograft, it takes quite a while. There's also less recurrence, about 50% less recurrence when you use fibrin glue for pterygium surgery. The last point is to always identify the rectus muscle. Now, if you look on the right-hand side, the American Academy report actually shows you the recurrence rates with different techniques. So bare sclera is the worst, where there's significant recurrence, and bare scleral mitomycin, also bad recurrence. Amniotic membrane, slightly less. Conjunctival autograft, conjunctival limbo autograft, much less risk of recurrence. So is there another technique to allow easy wide excision of tenons in pterygium surgery without needing an assistant? So the whole idea with the large tenonectomy is that you need somebody to help you lift things up, pull this here, okay, so that you can actually cut the tenons away. So Elsie and I published this novel unassisted pterygium excision technique, and we're using the pterygium as a third hand to basically help with the extended dissection of the tenons. And I'll just show you the video.
Pterygium excision with a conjunctival autograft is one of the most common anterior segment operations performed. However, one of the dreaded complications is recurrent disease. An important step during surgery, which has been shown to reduce the rate of recurrence, is an adequate large tenonectomy. A tenonectomy is easier to perform when a third assistance hand is present, as it allows the surgeon to hold onto the tenons layer with forceps with one hand, while the other hand separates the tenons from the conjunctiva using scissors in preparation for tenons excision. The assistant offers their third hand to hold onto the conjunctiva to allow visualization. However, we don't live in an ideal world. How often do we have a good attentive assistant? Most surgeons, unfortunately, operate solo. This new technique is a modification of the standard excision of a pterygium to allow large tenons excision with only the surgeon's two hands, eliminating the need for a third assistant's hand. First, the conjunctiva over the body of the pterygium is incised, leaving the underlying tenons layer intact. As the tenons layer remains attached and taut, it allows for easy dissection of the conjunctiva without the need for an assistant. The pterygium itself therefore acts as the third hand. The surgical sponge keeps the surgical field clear of blood, allowing clear visualization of the dissection. This same technique can also be used for excision of recurrent pterygia. After the conjunctiva has been dissected free, a surgical sponge is placed under the bridging tenons. This ensures that the medial rectus is not within the tissue that has been dissected and is about to be excised. The separated tenons is pulled forwards and excised maximally. The head of the pterygium is then dissected off the cornea. The superior conjunctival graft can then be harvested and fixed into position with sutures or with tissue fibrin glue.
And the glue layer needs to be thin.
This simple and new technique makes adequate tenonectomy in pterygium surgery easy to perform for any surgeon who operates without an assistant.
Sorry, let me just, yep. Okay, so you can see that when I did the excision, when I made the first cut, it's actually a very small area, but eventually ended up being about 14 by 14 millimeters. So what do we do differently in redo pterygium or recurrent pterygium? So the same main points: large extensive tenonectomy, a large autograft. I still use fibrin glue. I don't put any sutures with the use of glue. Make sure you identify the recti muscle, dissect around it. But I use mitomycin 0.02% for 3 minutes, just subconjunctivally. and put them on about 10 weeks of steroids, essentially. I use prednisolone forte eye drops for about 10 weeks. So at the moment, for recurrent pterygiums, there's no role with anti-VEGF, and intraoperative mitomycin has shown to be very effective, but you got to be careful, make sure you wash it out, don't leave it on for too long because it can cause other complications. Thank you very much.
Thank you, Elaine. Thank you, Elaine. That was a lovely video and excellent talk. We're going to do questions at the end. We'll have a little bit of a panel discussion. If you've mastered the question app, you can use the phone. Otherwise, we can also do it in the traditional way. Okay, so I'm talking next. Okay, so this lecture is on corneal ectasia and when is cross-linking needed. And I'm going to talk about keratoconus, keratoglobus, pellucid marginal degeneration, post-LASIK ectasia, and Terrien's marginal degeneration. So first to keratoconus and keratoglobus. As you all know, keratoconus is a progressive thinning disorder. It's bilateral, it can be asymmetric, and it results in irregular astigmatism. And in our everyday clinic, we see a range of patients with keratoconus. We see adults, we see young adults, and then children. And so for each patient, there's maybe different considerations in terms of whether they're going to progress and whether they need cross-linking. Particularly when patients are young, they're very anxious about the concept that their keratoconus may get worse and their vision may decrease. Oh, yeah, can you go back? So we conducted a systematic review to have a look and to see who actually with keratoconus progresses. And this included over 11,000 eyes, looking at outcomes with at least 6 months duration. And what we found here is each dot is a study, and the size of the dot shows the size of the study. And we found with increasing age, there was a reduced risk of progression. And with increasing Kmax, there was an increased risk of progression. But this data came from studies that were done before modern topography. It was nonetheless useful to clinicians who tweeted about it. Now, clinical registries have been established in ophthalmology and they're growing. And that's because they allow us to collect outcomes from the real world. And we have the keratoconus, I run the keratoconus Save Site Registry, which is a prospectively designed web-based tool with inbuilt quality assurance measures that can be used in routine clinical practice. If you participate, you can get CPD points and you can benchmark your practice against other doctors within the registry. So we currently have 92 users across 80 sites with over 37,000 visits with over 7,000 eyes. Now, we're interested in finding out whether, using our registry data, our findings were similar to what we found in our systemic review, because our registry data contains modern topography. So we, first of all, did it's just jumping around the place, did a workflow study to show that using the registry is compatible with everyday clinical practice. And then we had a look at our data within the registry, and we found a similar trend that Kmax, the steeper the Kmax, the more likely you were going to progress, and the younger the age, the more likely you were going to progress. So all over, if your patient is less than 21 years, they're more likely than if they're 26 years to progress. If their Kmax is greater than 55, we also found changes in K2 and K-mean to be sensitive measures that there might be progression. And the other important point is that this progression can occur within 12 months. So, and at different age groups. So if you're younger, you can progress faster. So having a 12-month follow-up for somebody that's young, you may miss the progression. We now have an optometry module where the data can be shared between ophthalmologists and optometrists. If you're cross-linking patients and the optometrist sends you a patient, that data can go from the optometrist to you and then back again. So basically, if you're young and have steep corneas, it is likely that your vision may get worse within a year, but you'll not lose your vision. And so these are good candidates for corneal cross-linking. So generally, the criteria to establish whether somebody needs cross-linking, there's no universal consensus. But generally, it's thought that there should be a change in at least two parameters, and steepening of the anterior corneal surface has been one of the key changes. You may also see steepening of the posterior corneal surface and thinning or an increase in the rate of corneal thickness change in keratoconus. Now, this table here shows the criteria that have been used in clinical trials to determine progression. And they relate to increases in these parameters from baseline. And so you can sort of apply these in your clinical practice, bearing in mind that the time period will vary depending on the age of the patient. And once you've decided that you're going to do the cross-linking, if we look at the outcomes of that using our registry data, you can say to the patient, look, it's likely your vision will improve and your corneal shape will improve, particularly within the first year. But these changes may actually continue up to 5 years after the procedure. So this front column here, the red bars, are the 1-year data, where you can see improvements in terms of vision, Kmax, K2. Adverse events also were more common within the first year and rare by the 5th year, but overall low. This is looking further at what happens over time after corneal cross-linking, and you can see a steady improvement in visual acuity that goes past the first year and a steady flattening in Kmax. There's an initial thinning in corneal thickness and then it increases. We've also looked at accelerated cross-linking, or this is another study supporting accelerated cross-linking versus long traditional cross-linking, and the outcomes for those two procedures are the same. But with accelerated cross-linking, it's more beneficial for the patient because the procedure doesn't go as long. If you do have patients that are having corneal cross-linking, you can download this brochure, which provides them information. So cross-linking, once you've done it, will have a lasting effect, but vision and corneal shape may improve over time. So definitely for progressive keratoconus, you should cross-link your patients because it has benefits. And you can reassure them, look, is it safe? Well, generally it's safe. The number of adverse events is low, the most common one being haze, and that can occur in about 14% of patients, but it generally resolves. In terms of our cross-linking patients, we can also say, look, if you're young and you're steep, so this is the people more likely to progress, you're more likely also to have haze after corneal cross-linking. So you may need to tailor their post-op treatment and give the right steroids. But what about pellucid marginal degeneration? So I've just figured this advances if you just touch it very slightly. There's not a whole lot of data in the literature to inform practice. This was a study that determined progression to be an increase of 1 diopter in the K value in the 2.5 millimeter zone, and they used central even though it's a peripheral disease. And if this occurred, they then did corneal cross-linking. Now, with pellucid marginal degeneration, because it is peripheral, you need a large treatment zone, or you may need to decenter the treatment. If you're doing that, you should ensure that the limbus remains protected. They reported that there was some reduction in inferior thinning of the cornea, some local flattening and decrease in corneal astigmatism, along with an improvement in vision with corneal cross-linking. What about post-LASIK ectasia? Well, corneal cross-linking can prevent progression. It can be combined with other treatments such as intrastromal rings, and this is still considered off-label. And how you determine progression and whether you need to treat these patients is by evaluating topography. You can look at the topography and use progression analysis on the Pentacam, including the BAD software. And the criteria you can use are similar to those that you use to judge whether your keratoconus is progressing. What about Terrien's marginal degeneration? Well, this is very slowly progressive. There's against the rule astigmatism, but most patients with Terriens don't progress to perforation. Astigmatism is their main problem. So this can generally be managed in glasses or contact lens wears. There are case reports of corneal cross-linking for this condition, but we don't have really good long-term data on the outcomes. So just to sum up, if you have corneal ectasia, keratoconus and keratoglobus, cross-linking is for progression, which is more common in the young. Monitor closely in the young as the progression may occur quickly. For pellucid marginal degeneration, there may be a role for corneal cross-linking. You need to, again, look for progression. And when you're doing the treatment, think about where the ectasia is and decenter and make a large treatment zone. Post-LASIK ectasia, you can follow similar guidelines to those for keratoconus. And in Terran's marginal degeneration, look, I think it's still very experimental. We don't really have much data at all. And progression is more likely if you're young, within 3 months. If you're older, over 12 months. You can use progression analysis or look at 2 parameters. And for keratometry parameters, you're looking at changes of around 1 to 1.5 diopters. The other thing, though, that comes into all of this is that the scans should be consistent. They should be performed on the same machines, because the steeper you get, the more variability in your keratoconus there is. So you can have up to 3 to 4 diopters variation in a scan for patients with keratoconus if they're particularly steep. So make sure the data that you're getting from your topography also matches clinical parameters such as changes in vision and spectacle refraction. This is the SaveSight Registries team, and if you'd like to join, be in touch. Thank you. Okay, so next we're going to hear from Dr. Himel Kandol, who's going to inform us on how we can use patient-reported outcomes in everyday practice. Dr. Kandol is a postdoc researcher, the Kornhauser Research Associate at the SaveSight Institute at the University of Sydney.
Thank you, Stephanie. Hello, everyone. I'm presenting on how can I use patient-reported outcomes in my everyday practice. My talk will be mainly divided into 2 parts. First, I will discuss a brief theoretical background on patient-reported outcomes, followed by sharing our experience of using them at the SaveSight Keratoconus Registry. First of all, the FDA defines patient-reported outcomes as any report of patient's health status that comes directly from the patient without interpretation by the clinician or the researcher. And patient-reported outcomes include quality of life outcomes, which again have a number of domains, including symptoms, physical, emotional, and social functions. Commonly, patient-reported outcomes or quality of life outcomes are evaluated using questionnaires or more recently item banks. There are a number of advantages of using patient-reported outcomes in routine clinical practice, and this figure highlights one of them, is to reduce the disparity between clinicians and patients' perspective. In this figure, you can see there's a doctor here in a keratoconus patient. Doctor is saying, fantastic, with these scleral lenses, you can see almost 6 by 6. Doctor is very happy about it, but many things are going on in patient's mind. I can read letters, but they look distorted, and I see halos and ghosting around light. The prescription is getting worse and worse. I'm scared that I might be blind one day. Are these lenses going to help me with the glare and light sensitivity? Will I be able to drive at night? Will I be able to wear these lenses? My eyes are already so dry. So many things are going on in patient's mind, and patient-reported outcome measures can help to bridge the gap. Similarly, another importance of measuring patient-reported outcomes is to raise missed out patient issues. Usually, clinicians is the tip of the iceberg, but many quality of life issues, especially the emotional well-being issues of patients, are often unnoticed by the clinicians. The FDA has now recommended that patient-reported outcomes should be part of the comprehensive outcome assessment. So it is important to measure patient-reported outcomes, but there are, of course, several challenges as well. When you say measuring patient-reported outcomes, it does have to follow the basic measurement principles, which are measuring patient-reported outcomes or quality of life or satisfaction or love or happiness. These are latent traits, and measuring them is not straightforward, like measuring length, weight, height, but they do still need to follow the basic scientific principles. But it might need complex skills to do that. And we all know that measuring patient-reported outcomes comes with respondent and clinician burden as well. And some other challenges are the non-standardization. Um, there are a lot of tools available, but the most of them have poor quality. And I, s- I like to say that there is a toothbrush problem in when it comes to patient-reported outcomes. Like usually the clinicians or researchers who have developed those tools or methods, they hesitate to use other people's tools. It's just like nobody wants to share other people's toothbrush. Another challenge in patient-reported outcomes is that real-time use of patient-reported outcomes is often not possible. It's some sort of calculation needs to be done. We have addressed most of the challenges in the Safe Site Keratoconus Registry, which is, as Stephanie mentioned, which is an international patient database of patients with keratoconus, where we track natural history and treatment outcomes in keratoconus. And in the Safe Site Keratoconus Registry, we do the real-time evaluation of patient-reported outcomes using the keratoconus outcome research questionnaire. Briefly about the registry, we have 92 clinicians from 80 sites in Australia, New Zealand, Spain, Italy, France, Germany, and Switzerland. And we have data from over 36,000 patients, clinical visits of over 7,000 eyes of 4,000 patients with keratoconus. And in the registry, initially we started collecting patient-reported outcome data using the impact of vision impairment questionnaire, which is a very good quality questionnaire. And we have done several studies to answer important research questions, like one shown here, comparing the impact of keratoconus with other eye disease. So this is very useful, but thing lacking is it is not specific to keratoconus. So it may not have issues. It may not be very sensitive to people with keratoconus. So we did a systematic review. So whenever you are trying to choose an appropriate patient-reported outcome measure, the first thing is to find out if there is any systematic review which has looked into different tools. We found that there was no systematic review conducted earlier, so we conducted a systematic review, and we found that keratoconus outcome research questionnaire was the only valid keratoconus specific questionnaire available, and we use it in the registry. But when we are using a tool, first we need to determine. First, we need to check if it is working very well in the registry population. So, obviously, the development population was not identical as our registry population. So, we evaluated the psychometric properties using the modern psychometric methods, and we found that it worked really well. I wouldn't go into details of the psychometric properties here, but just to highlight like what we do when we use a measure in a particular setting. And we also need to consider different validity tests and reliability, which means how consistently accurate scores or data we are getting, and as well as responsiveness, how sensitive is the tool to capture the change in outcomes. These are some other considerations we need to make. And some of our users in Spain, they wanted to use the Spanish version of the questionnaire. And whenever the tool has to be translated into a new language, it has to undergo through a rigorous process of forward and backward translation. So this flowchart is showing here the process, but so that the Spanish version is equivalent to the original English version. So at the Safe Site Keratoconus Registry, we routinely collect patient-reported outcomes. Usually, it is done in the clinics or in the waiting rooms, in paper or through the iPad. When it is done through the iPad, it is often done. It's a web-based system, so it automatically goes to the system. And then as soon as the patient completes the questionnaire, the scores are there. It is a screenshot from the registry here for a patient. then doctor will be able to see the scores and compare with the previous visits. And then this is a new update from the registry now. Actually, we can send the link to the patient's device, and then they can fill out the questionnaire using their own device. So the registry patient-reported outcome data has been very useful to understand important research questions, such as this is one of our recent paper which has identified the factors which are affected in patients with keratoconus, and to improve what can be done to improve quality of life in those cases. And these are the references I used in my today's talk. And to conclude, patient-reported outcome measurement in ophthalmology is rapidly evolving, and appropriate methods are critical, and which includes appropriate high-quality pro measures use. And the ultimate goal should be to the ability to use pro data for patient benefits. And if you are interested more about the registry, here is a link, and we also have a booth at the exhibition hall. Thank you very much.
Thank you. I now have the pleasure of introducing Dr. Tanya Trin from the Corneal Unit at the Sydney Eye Hospital and Mossman Eye Centre. And she's going to be presenting on, is there anything new for Fuchs corneal dystrophy?
Okay, so the title of this session in total is What Do Corneal Specialists Tell Their Patients? So there's a large focus of that in this talk. So what do I tell my patients, and what do I tell my referring optometrists as well when it comes to dealing with Fuchs dystrophy? So just a brief outline of Fuchs dystrophy as a recap. It's a non-inflammatory dystrophy involving the posterior layer of the cornea. Eventually, when it degenerates, it swells, causing glare and halos and reduction in visual acuity. And it can be so severe as to cause corneal blindness from scar tissue or pannus formation, as it gets quite inflamed as an endpoint. There is a slight female preponderance. About the age of 40s to 50s is usually when we start to pick up the subtle changes, mostly autosomal dominant or sporadic in terms of the genetics that we've found, but that's not always the case. And the principle in the treatment of Fuchs dystrophy is when we've decided that the patient eventually needs surgery, that we remove the diseased tissue, replace it with functioning tissue, preserve the functioning tissue as long as we can. And now the question really is a bit of a game changer, is can we regenerate any of this functioning tissue? So what might you ask a patient with Fuchs endothelial dystrophy? I want to ask about what they're experiencing in terms of visual quality. Are they experiencing glare and halos? Are they getting diurnal variation? Is the period of time that they're getting blurry vision in the morning compared to the afternoon stretching out longer and longer? Do they have pain? So for those with the quite advanced Fuchs dystrophy, I want to know if they're getting ruptures of bullae and causing foreign body sensation and inflammation. And what is this impact on its functional status? What are they feeling safe to drive? And are they able to continue doing their work? There are a number of masquerades with Fuchs endothelial dystrophy that the clinician might want to consider. And what are the things to look out for? So in terms of the endothelium, so I always encourage my fellows and my registrars to make a systematic habit of looking at the tear film, the epithelium, stroma, and endothelium. But on the endothelial level, what are your guttae? Are they present? What do they look like? And what's their extent? So classically, we describe it beaten metal appearance. There is a certain granularity that you can pick up. And the distribution is really important in terms of determining your type of therapy. So is it central or is it peripheral? And usually it starts centrally and migrates outwards. Is there associated edema present? Are there desmoid membrane folds? Does the cornea just look thick even though it's clear? And what's the patient's phakic status? Is the eye quite complicated? Because that will also change your surgical management as well and the way that you counsel your patient. And these are a number of changes that you'll see clinically at the slit lamp, going from less severe to more severe at the bottom. So in terms of corneal grafts, is a little bit of alphabet soup if you're not in the area, but suffice it to say on the left-hand side of the slide, we used to have full-thickness transplant options for endothelial dystrophy. We are now moving to partial or posterior lamellar transplants. DALC is not obviously a part of this, but in terms of DSEC or DMEC, and now really we're evolving into the Decimate stripping entity. This is not actually a transplant, but seeing if we can regenerate some of that tissue. What we'll be focusing on today will be these two areas. So according to our Australian Graft Registry, there's an increase in the number of DMECs and DSECs, and that's eating into the pie that used to be occupied by our penetrating keratoplasties. And this is good reason, because we want to be able to give patients a restoration of function with a decrease of the rate of their complications. Now, the gold standard around the world is still a DMEC, so that's your thinnest transplant available. It's the most minimally invasive. This is what I tell my patients. It's the thinnest transplant, so that's the least rate of rejection. It has the fastest recovery rate and has the best visual clarity, at least from a refractive perspective, but it is slightly technically demanding. The DSEC is still a great option for Fuchs endothelial dystrophy and really shines when we have complicated eyes that have had previous trabeculectomies or tubes, eyes that have been vitrectomized, and therefore still a key player and still a really important technique for corneal specialists to know. And certainly in your aphakic and anaretic eyes as well. And then, of course, we go back to penetrating keratoplasty. Usually I would pull this out in these patients when all other partial thickness transplants have failed. So in terms of a DSEC, just to remind people, we are replacing the posterior layer with a little bit of stroma, so it is a little bit thicker. And this surgical video here just demonstrates that when we pull this tissue through, there is that element of chunkiness to the graft, but this actually allows it to unfold quite nicely in complicated eyes without too much fuss. In terms of a DMEC, this is our thinnest transplant, so now we are just really replacing that posterior layer. It is extremely thin and extremely fragile, and as we stain the tissue and inject it into the eye with the girder injector, there is a little bit of tissue manipulation involved, and that's why we tend to prefer these in eyes that are less complicated to allow the transplant to unfold quickly and hold on to the number of cells that were given from the eye bank. But DMEC is not easy to do, although it is my favorite, and we seem to have just flicked over a couple of slides there. DMEC is not easy to do, but is one of my favorite procedures. I'm not sure if this video is going to work here. But tissues can shoot backwards, the tissues can spit out of the eye, tissues can go around the lens, tissues can go around the back. You can actually have this happen with DSEC tissue as well. Eventually, we have to fish it out and see if we can use the tissue or even come back to fight another day. So for good reason, there will be the proportion of surgeons that will still stick with DSEC, but that is still a great procedure for this. In terms of when we're putting it into place, it is floated into position with an air bubble. And so you can see here that when we mark the patients if we don't have access to anterior segment OCT or other methods of marking, which might include cutting chunks out of the tissue or looking at the tissue orientation in a relatively clear cornea to see if the tissue is pointing upwards, then it can be quite challenging to get the tissue in the right orientation. We use the letter F because it's a non-reversible, as in you automatically know if it's upside down in the eye, and we're trying several attempts to try and get it upright. This is a great technique for my fellows to start with if you're going into operating on your own for the first time, choosing your cases carefully and making sure that you've got some backup with marking and unfolding. And I'm just not going to finish this video in the interest of time. So what do I tell my patients? What can they expect? So DMECs are more surgically challenging, but from the patient perspective, the visual outcomes between DSEC and DMEC is kind of similar, although DMEC is more anatomically a better match and thus less of a refractive shift. Rejection rates are lower with DMEC than DSEC just because we're transplanting less tissue, and similarly so with DSEC compared to PKP. Failure rates are extremely low, provided that you've had relatively routine surgery and relatively minimal tissue manipulation and a relatively uneventful postoperative course. The recovery period is quite fast, so they're clearing over 4 to 6 weeks, but attachment is absolutely crucial in the first week. Rebubbling is fairly easy to perform in these cases, with the first week being not uncommon, so it's important patients know that the transport options and them lying flat on the way going home needs to be considered. And when they can get glasses again, usually I would wait 3 months to clearance. But remember, with your thicker transplants, there is a certain degree of sutures that you need to remove and also waiting for astigmatism to resolve. And so their refraction will often shift. In terms of staying, overnight stay, there's a 1-night stay in hospital for my patients. Some patients will be sent home. They lie on their back for a couple of days and we check them day 1, week 1 and month 1, month 3 and month 6. And we use antibiotics for a week and then steroids for a period of time. And I usually wean mine quite slowly over every 3 months. NSAIDs are generally not needed for this. But what if we can avoid a transplant altogether? And because transplants are not uncommonly associated with rejection, graft failure, steroid-induced cataract, steroid-induced glaucoma, as well as dry eye disease and ocular surface disease from exacerbation of using drops on multiple occasions, and of course with altered visual outcomes. And so DWIC or DSO has really come into its own and was invented by Dr. Greg Maloney, one of the Corneal staff at Sydney Eye Hospital, and first wrote about this in 2015 with Decimase for Fuchs dystrophy, and essentially came about serendipitously with a patient who had a little bit of the Decimase sucked up during a cataract surgery, and while they were waiting for a DMAC, actually managed to replace and regenerate their own endothelial tissue. So this is the first case series of that report, and then so one of that case, and then one where they actually manipulated the tissue, took away the Decimase, and then it regenerated by itself. As we go, so really what the game changer here is we previously thought that endothelial tissue could not regenerate, and this is why we were replacing it. But we're really realizing that there is a certain potential for regeneration. We're trying to find out what those limits are and what is its place in the treatment arsenal. Can we avoid a transplant altogether? Can we delay a transplant? And is that a good thing for our patients? Can we minimize morbidity when it comes to ocular surface disease and drop toxicity and rejection? So in terms of ROCK inhibitors, it is an adjunctive therapy that we use to help boost, and the way I tell this to my patients, as it kind of helps stimulate or fertilize the endothelial cells to cover an area of turf where your grass is missing, and we get a repopulation from the periphery down to the center. The topical Repastil has been used, but essentially ROCK inhibitors do vary in their distribution around the world, but Nedosudil has also been another agent that has been used as well. Recently reported on 12-month outcomes in 2021 of that same group. And essentially, we have probably got our patients coming up to about 5 to 8 years, but not large numbers, obviously, as the technique was only recently discovered, but quite a good recovery rate in terms of endothelial regeneration. But it all comes down to patient selection. This is just a case report of our 5-year outcome of one patient who's still going strong. So who is a DWEC or DSO candidate? It's essentially an individual with central guttae with glare. So these are symptomatic patients wanting a solution with no or minimal diurnal variation. They have a clear periphery, and on in vivo confocal microscopy, we are looking at if they've got a peripheral cell count of over 1,000. Usually we look at the superior tissue, and we generalize, or we think that that's because it's not been yet exposed to UV exposure. They've got good vision in the other eye is paramount because the patient still needs to be able to get around and walk around with it at home. And they need to be prepared to have a DMEC in the event that it fails. So it's really important that we counsel our patients that the DMEC is not an inferior procedure. We are, at the moment, the way I counsel my patients is we're just delaying your need for a transplant. If we can delay it forever, that's great, but you will still need to consider it in the event that it fails. So recently we'd reported on the medium-term failure of DSO only with pan-corneal guttae, and that doesn't work. So these are patients who have confluent guttae all over the posterior surface of their eye, but generally are not good candidates here because they don't have any healthy cell reserve. So when do I like to see these patients? I like these patients to be referred early so I can at least have that conversation with them. So patients do come quite frustrated when they're beyond or that moderate severe stage and I'm not able to offer this procedure or at least consider it with them. The pros with this procedure is there's no graft, so there's no steroids, and fast responders will clear within 4 to 6 weeks, slow responders within 4 to 6 months, and then we have our non-responders, in which case we will need to move to a transplant, and I can't tell patients how long yet this will last for. The expanded roles of ROCK inhibitors is also a whole lot of research going into these. We are looking at this in terms of rescue therapy for failed transplants. There are case reports of using this for high drops resolution without needing to use much in the way of interventional surgical therapies. And you can see here that the air bubble here is quite nicely demonstrating the central guttae. And after the cataract is performed, we're actually this can be performed with cataract operation at the same time. If you've got early biometry, because you've got the patient at the earlier stages, it's good to compare that biometry. But when we're looking at this, we're marking the center 4 millimeters and stripping that tissue away with a modified Gorovoy forceps or a Decimase stripper of your choice. It's really important that when we're doing this, that we're not elucidating any stromal damage and causing any increased scarring, and very delicately almost doing like a reverse rhexis, but on the endothelial case. I'll skip through this case studies at this point, but suffice it to say these images of normal and abnormal cornea is what we use to judge a patient's suitability. This is just a twin of a patient who ended up quite well, but the other twin, after hearing how his brother had done, came in for his assessment and actually was not a candidate, as you can see from those images here. So what can you tell them? This is a treatable condition. A lot of them will need just watching for the majority of their lives. You may never need treatment. There are about 4% of people with guttae-like changes and not quite Fuchs who won't need any treatment. But the prognosis is excellent even if you do need a transplant. If you do deteriorate, it's likely to be slow, and there are modern day options that are continually improving, which may delay your need for surgical intervention. But remember that the DMEC transplant, don't demonize this for your patients. You are setting yourself up for failure. And so patients shouldn't despair, and remember to counsel your patients in terms of cataract involvement as well. So when to refer early, and thank you very much. Thanks.
Thank you. We're now going to have a pre-recorded presentation from Dr. Andrew Appel, who's actually from Brisbane. And it's going to be on, does my patient need a surgical solution or laser superficial keratectomy? Hopefully that will play very soon. Remember to put your questions in the app.
Good afternoon. Thank you for the opportunity to be involved in the seminar on the management of common corneal disorders and what corneal specialists tell their patients. My topic for this afternoon is, does my patient need a surgical solution or a laser superficial keratectomy? As we're aware from anatomy, the cornea consists of 5 layers: the epithelium covered with a tear film, Bowman's membrane, stroma, Descemet's membrane, and the endothelium. Superficial diseases which cause an irregular surface and an abnormal tear film have much more effect on vision than stromal opacities. So if we can make the surface smooth, the quality of vision will be improved. Therefore, superficial corneal disease can be divided into acquired or congenital. Acquired diseases, which involve the epithelium, Bowman's membrane, and anterior stroma, include filaments of the epithelium, Solzmann's nodules, pterygia, keratoconus, where there's apical scarring, and scarring associated with corneal transplantation. The common hereditary diseases that we see are corneal dystrophies, map dot fingerprint, Meesmann's, and Rees-Buckler's. There are a myriad of lesser known dystrophies as well that can affect the cornea. Deep disease, which involves the stroma, descemes, and endothelium, often requires a full thickness corneal transplant or some form of lamellar transplant and will not be discussed. You can see here on the anterior OCT photographs how abnormalities of the Bowman's membrane eventually affect the epithelium and subsequently the tear film, thus causing problems with vision. These are examples of Rees-Buckler's dystrophy. In general principles which involve laser, phototherapeutic, or photorefractive keratectomy, Bowman's membrane and the anterior stromal opacities can be treated. The aim is to regularise the corneal surface and improve transparency. Masking solutions can be used, which involve sodium hyaluronate, and these combined with mitomycin C to prevent formation of subepithelial fibrosis or haze can improve the surface. At the same time, we can improve astigmatic, myopic errors. We must remember that the laser induces a hyperopic shift, which can be problematic or can be used to our advantage. Also, be aware of patients who have had past history of herpes simplex keratitis need to be covered with oral Valtrax to prevent recurrence of the disease process. Usually laser treatments are better formed in patients who have diffuse rather than focal disease. So looking at this flow chart, we can see that if the epithelium is smooth, we can do what's known as a transepithelial ablation, which can be to our advantage because it reduces the hyperopic shift associated with the laser treatment. However, if the epithelium is irregular, we need to remove it prior to the treatment. This just shows you what happens in the laser room. It is a walk-in, walk-out procedure with minimal intervention to the patient. No patches are required afterwards, and the procedures are done under topical anaesthetic and relatively quick to perform. In terms of transepithelial phototherapeutic keratectomy, if we're treating astigmatism, we can do a cross-sill technique, which involves treating both the plus and minus components of the astigmatism, which reduces the amount of tissue ablated, also reducing the amount of hyperopia induced, and also does help us with irregular corneas. We can also type into the laser some degree of irregular treatment as well to smooth out the surface. You can see here on the OPD scan how the improvement in the surface has, how improvement in the topography has occurred after treatment. Most patients improve when they have diffuse disease using a laser. And you can see this patient who has an Avellino variant of lattice dystrophy has had ablation of the anterior stroma as well as Bowman's membrane. And you can see 1 month after the surgery how much clearer the cornea is. And as well, there is this associated smoothing of the surface as the treatment healing progresses. In terms of surgical options, the general principles either involve debridement of the epithelium using a blade or even treatments with a needle in terms of a puncture. If there is a superficial scar, this can be excised or peeled, as you can see here. If we try and use a laser to treat these sort of problems, there is different ablation rates between the scar tissue and the normal stroma, which causes changes in the outcome between the different areas. Be aware that epithelium is good at filling divots, but can't grow over humps on the cornea. So if you can remove a hilly area, then the epithelium will come back more smoothly. Usually, blades and needles can be used to treat more focal disease rather than a laser. Just to show you some examples, here's Salzmann's nodular degeneration of the cornea, which presents as raised grey-white areas in the periphery of the cornea. They may be unilateral, bilateral, or multiple in nature. They're slowly progressive, and they can occur as an idiopathic cause or be associated with chronic corneal irritation of various sorts. Conservative management usually doesn't go on for very long and generally involves lubrication and improving the irritative phenomena that cause the underlying condition. Surgical intervention is usually performed to smooth the surface and involves a superficial keratectomy, as you can see here, where Bowman's membrane is generally intact underneath and the area is simply removed, a bit like removing a piece of sticky tape off a surface. Mitomycin C, as I mentioned earlier, is used as well to prevent further corneal haze associated with the treatment. This shows you a case study of a 62-year-old male with blurry vision and an irritable eye who had no real astigmatism associated with the myopic error, but you can see on the pictures how irregular the corneal surface was and how the OPD was distorted. A trial of Muro ointment and lubrication was used but didn't have much of an effect. The patient went on to have removal of the scar, and this shows the outcome 1 month after the procedure involving mitomycin, and then also at 9 months after the procedure. So you can see how the cornea is smooth and there's been no recurrence of the disease process. With regards to recurrent corneal erosion, this presents as a painful, often unilateral eye upon wakening, usually in the early hours of the morning. It can also be associated with underlying basement membrane dystrophy and is often bilateral in these cases. A typical example is map dot fingerprint dystrophy. The usual cause, however, is trauma to the cornea, such as a fingernail injury, a paper cut, or even a plant being poked in the eye. Patients can also have had previous trauma due to refractive surgical procedures, cataract, or even corneal transplant surgery. There may be underlying dry eye disease. It can be associated with diabetes and blepharitis or rosacea. You can see here the disturbed epithelium. These patients are often quite sensitive in terms of the pain that happens with the disease. Treatments are medical or surgical and involve lubricating drops, hypertonic saline ointments and drops, which are used for about 6 weeks, possibly in association with bandage contact lens and steroid drops. Surgical intervention involves antiostromal puncture and epithelial debridement. This can be used either with a diamond burr for polishing the surface or even associated, if the area is quite large, with a phototherapeutic keratectomy or refractive keratectomy. You can see here in the diagram how the needle is used to puncture the antiostroma. This allows the hemidesmosomes to grow back in place and stop the erosion from occurring. The area needs to be treated adequately and identified prior. Filamentary keratitis is characterised by filamentous threads on the anterior corneal surface, a mixture of mucus and epithelium. There is a foreign body sensation, which is quite chronic and can be associated with various ocular and systemic conditions that affect the tear film and ocular surface. It can also be associated with dry eye disease. You can see here the filaments with fluorescein staining. Treatments again can be divided into medical or surgical intervention, lubrication, perhaps even Botox, bandage contact lenses, and the commonest one that I find useful is N-acetylcysteine drops. However, these need to be made up as a proprietary medication. Surgical intervention involves simple filament removal, epithelial debridement, or phototherapeutic keratectomy or refractive keratectomy if the area is quite large. Often these can be focal, but occasionally they are quite large, these areas over the surface of the cornea. So in summary, what do I tell my patients who have these sort of disease processes? Superficial disease can be treated with either blade or laser or combinations. An irregular epithelium needs to be removed before any of these procedures are undertaken. If the epithelium is regular and the disease is diffuse, a laser can be used, or if focal, a simple blade. Bowman's membrane and the antiostroma and diseases of the antiostroma usually require a blade to treat them, as they are often focal in nature. Adjunctive mitomycin C has a great effect in controlling subepithelial fibrosis. Also remember, I'd like to say in closing, to remember that an irregular surface causes more visual disturbance than stromal disease does. Thank you for your attention.
Okay, so I'd now like to introduce Professor Richard Mills, who's going to talk on what should I do with pigmented conjunctival lesions. Thank you, Richard.
Thanks, Stephanie. If you're anything like me, when a referral comes in and a patient's got a pigmented conjunctival lesion, your anxiety level goes up, because often the referral will either say, is this lesion a melanoma, or the patient is going to ask you, is this a melanoma? And of course, melanoma is a bad diagnosis to get. And when you look at them on the slit lamp, what you ask yourself is this pigmented lesion likely to be benign or malignant? Because that's your role. And I'd like to show you the clinical features that allow you to make the diagnosis that can give you the confidence to tell the patient what you're going to do. And those clinical features will largely be determined by their age, the clinical history of the lesion, and their clinical examination, and how it has changed over the time, either on history or by your documentation and observation. And occasionally you'll be guided by results of histopathology. So we classify pigmented conjunctival lesions into these 5 groups. There's racial melanosis, ocular melanocytosis, conjunctival nevus, primary acquired melanosis, and then melanoma. And it's the last 2 diagnoses that we need to be a little bit more careful with. Racial melanosis is bilateral and it's been present for years. It's variably pigmented and they're flat areas, there's no cysts, and it often surrounds the limbus and involves the interpalpable zone. And it's more common, obviously, in Asian, African and Hispanic racial groups, but does occur in Caucasians, but no treatment is required because it's benign. Ocular melanocytosis is a congenital condition of the periocular skin and sclera, orbit, meninges, and even the soft palate. And there is no conjunctival epithelial pigmentation, even though it looks like it. It's flat, grey-brown pigment posterior to the limbus on the sclera. And there is a rare risk of uveal melanoma, not conjunctival. So if you're going to follow them up, it's to observe for uveal melanoma, not to observe for conjunctival melanoma. Now, conjunctival nevus is one of the more common presentations, and they tend to be younger patients than others with pigmented lesions, and they've often been present for a long time, even from childhood. They generally occur on the bulbar conjunctiva, but of course can occur in the caruncle, and mostly are pigmented, but occasionally you will see a non-pigmented nevus, and it can be confused with things like lymphangiectasia. The thickness is generally less than 1 millimetre, and often there are cysts associated with it, more often than not, if you look carefully. The whole lesion may be cystic, or just a proportion of it may be cystic. And in Jerry Shields' study of over 410 nevi, they noticed that there was a change in colour in about 13% of nevi over time, and only an 8% documented enlargement, even though patients come back and say, oh, I think it's got a bit bigger. If you look at the photograph that you took a year ago, it's exactly the same size. And there is a rare malignant transformation in these lesions, and so the real treatment is to reassure the patient that it's unlikely to be melanoma, and you're just going to take a photograph and observe them most of the time. Just beware of a rarer condition called giant conjunctival nevus. Again, occurs in young people and often presents in children, and so the anxious parent will come with the child as well. But these are large conjunctival nevi, over 10 millimetres in diameter by definition. They are usually on the bulbar conjunctiva, and they can involve the limbus and even encroach onto the cornea, and so they look a bit more alarming. They're thicker, up to 2 millimetres in thickness. They're quite cystic. They often have feeder vessels, which raises your alarm, and they can change in colour, and they're certainly more likely to enlarge, particularly at puberty. Again, however, in Jerry Shields' group of 32 patients he followed over time, there is a very rare malignant transformation, and so you just need reassurance, photography and observation, and generally they won't change over time. Now, primary acquired melanosis is defined as one or more patches of acquired asymmetric flat non-cystic conjunctival or corneal brown pigmentation. And this occurs in a slightly older age group than nevi, and accounts for about 1/5 of melanocytic lesions. And they're much, much more common in Caucasians, and for some reason there is a slight female preponderance. Now, they're almost always unilateral. Again, Jerry Shields has one of the largest groups of patients followed, and they looked meticulously in the other eye for any signs, and even a very tiny little skerrick of pigmentation they called primary acquired melanosis, and so their incidence of bilateral disease is slightly higher than we would probably expect in the community. Again, it invariably involves the bulbar conjunctiva, and about 50% of the time involves the limbus and can encroach onto the cornea, as in this patient. And the mean involvement at diagnosis is about 3 clock hours. And after 10 years, up to a third of these lesions undergo enlargement, and about an eighth of them transform into melanoma. So these are the ones to watch. However, there's an interesting observation from Shields' group, and those without atypia or with mild atypia, none of those cases turned into melanoma. And so patients can be reassured if you know whether there is atypia, no atypia or mild atypia. However, the ones to identify are those with severe atypia, because 13% of those turned into melanoma. However, in this particular group, none were metastatic at the time. The extent of involvement is most predictive of recurrence after surgery and progression to melanoma. So the wider the area of involvement, the much more likelihood they are to progress to melanoma. The management is, if a small lesion and it doesn't look nasty, it hasn't got very black areas that are thickened, then you can photograph them and observe them, because most of them aren't going to develop melanoma. However, if you feel a biopsy is indicated, it can be either incisional or excisional, depending on the extent. And this is combined with adjunctive therapy, usually cryotherapy at the time of surgery to the edges of the conjunctiva that's not excised. And then post-operatively, either with topical mitomycin C or interferon alpha-2b. And then you must follow them up. I'll just anecdotally show you this patient that I've been showing you images of. She was a 75-year-old lady, presented with PAM. It looked nasty. It had a lot of black thickened area at the limbus involving the cornea, even down into the caruncle, which looked suspicious. So she had excision and cryotherapy and was followed and recurred, and the recurrence looked nasty. She had severe atypia, so I was worried about melanoma. However, I didn't want to do more surgery, and she didn't want to have more surgery. So she had one course of mitomycin C, 0.02% QID for 4 days, and the lesion completely resolved, even down in the caruncle, and she was free. This is a picture 5 years later. So it can be exquisitely sensitive to mitomycin C, even at low dose. And this was published by Jern, Yi Chen and myself in 2007. Now, conjunctival melanoma, on the other hand, occurs at a slightly older age group in 90% Caucasian, and there is an increasing incidence. 75% arise from primary acquired melanosis and in older patients generally, and so you need to watch those. Only a smaller proportion will arise from nevi and tend to be in younger patients, and 15% de novo. But the origin of the melanoma does not affect the outcome. If it's arising from a nevus, it tends to be thicker, there are feeder vessels, and the histopathology and studies show there are more BRAF mutations like cutaneous melanoma. If it's arising from PAM, then there are greater clock hour involvements, there's more previous surgery generally, and there's more recurrences. But the tumour origin, again, doesn't have any effect on exenteration rates, metastasis rates, or death rates. The surgical management is on-block tumour excision with at least 3 millimetres of conjunctival margin. You remove the underlying tissue to bare sclera, a double freeze thaw of the conjunctival margins, and then localised corneal epitheliectomy if necessary, and conjunctival reconstruction, and then adjuvant treatment. And the adjuvant treatment is where you get your local ocular oncologist involved, because they tend to treat these more aggressively, and they'll certainly consider applying radiotherapy to the area, even if it's been cleared histologically. and this is usually preceded by chemotherapy, mitomycin or interferon. The molecular and immune-based therapies are generally reserved for those with metastatic disease. So, what should I do with pigmented conjunctival lesions? I think if there's ocular melanosis and nevus or mild-looking PAM, then photograph it and observe it. If there's suspicious-looking nevus, acquired melanosis or a melanoma, you must biopsy and provide adjuvant therapy and follow up, usually in consultation with an ocular oncologist. Thanks very much.
Thank you, Richard. So we're going to open up to question and answer now. So we've got some on the app, and if anyone wants to ask one the old way, that's also fine too. So Elaine, so fibrin glue, can you tell us anything about dehiscence rates?
Yeah, so there's a few studies showing that there is slightly higher risk of dehiscence and complications with fibrin glue, but it really depends on how you use it and the familiarity of the glue itself. So personally, when I was training at SNEC, everybody used fibrin glue. It is not published. This is not published, but I have not seen in the 2 years in Singapore National Eye Centre, when everybody uses glue, any dehiscence with the surgeons that I've worked with. And personally, in Australia, I haven't had any dehiscence rates as well. Okay, so the way from the question, it was how do you actually apply the glue? Well, when you apply the glue, make sure that the glue is completely transparent. So I use artist glue versus Tesil. Tesil sets faster, artist sets a little bit slower, so you have a little bit more time. Make sure that the glue is completely clear. So sometimes there's been 3 incidences where the glue was not clear, and when I pressed it out, it was a bit more gluggy. So the glue, both tubes, so you have 2 tubes, one fibrin, one thrombin, when they mix together, that's when it basically sticks. So if one tube is a bit thicker and when it comes out it's not completely liquid, that's when you will have problems. So there's been 3 incidences where the glue was faulty, so I had to open another set of glue. So you need to get familiar with the glue itself, and when you put the glue on, make sure that it is a thin layer. Just put a thin layer on the bit, a little bit underneath the conch where you've cut the conch out, and then put some on the actual conch autograft itself, drape it over, and you want to use as a smooth instrument to actually push the glue away so that it is actually a really thin layer of glue. And then you crimp the edges like a pie or curry puff if you come from Southeast Asia, so that it actually sticks the two sides together, and crimp it a little bit and let it set for 3 minutes. You got to test it at that stage. So with your same instrument that you've actually milked the glue away, test it, make sure that it's actually stuck down, it doesn't move, then you're safe. So in those instances where the glue didn't work, when you move it, the actual conch does move, so that's not good.
Thank you. Any other tips from the panel on using glue?
Hello. I think if you're using glue for the first time, it's important to make sure that you do oversize your graft a little bit too, because it does retract. And if you're going to be doing a recurrence, you may wish to think about having a couple of anchoring sutures if you're running short on tissue and you're trying to cover a large area. I find the angled McPhersons, I love the technique of ironing things out. What I'll usually do is when I iron them out, I actually will overlap the host tissue over the border so there's no edge for you to kick up and for the patient to dislodge, although the crimping works well as well.
I don't know if you want an old dinosaurs comment, but my registrars kept asking me, why do you still suture a pterygium? And I said, well, I've never had a dehiscence. And they said, oh, you won't get a dehiscence with glue. And then the very next day, there was a patient on the list with a dehisced glued graft. So I don't feel embarrassed about suturing these lesions. It still works. I use a running 10-0 nylon anchored at the limbus. I take it out at 5 or 7 days. Patient's got swelling and irritation anyway, so the stitch is cut short so they don't really feel it. It's a running suture and it gets taken out by a week, and so don't feel embarrassed about suturing.
So just a bit of statistics. There is actually a slight, maybe 30% complication rate with the glue. So you really need to get familiar with it. And if you're using it for the first few times, some doctors have actually placed a few anchoring sutures at the limbus just to make themselves feel better. So you can definitely start off that way first. And if the graft is a bit too small, you can actually, because it's glue, and you can actually make slits like, a fish netting, and you can actually stretch the glue, and it also works well. So the glue also works in that way when you don't have enough conjunctival autograft.
Yeah, look, I think that's a good tip about the stitches at the limbus, particularly if you're starting out, because, a lot of these procedures you're doing for, comfort, but also they want a good cosmetic result. And if you have a graft that's lost, and I've seen patients where there's just no graft there, that you then have a very hard time getting a good outcome.
The really important thing is a big graft. I think you've made that point, Elaine, very well. You don't want a small graft, you want large tenons excision, big graft, and then you won't have to worry about recurrence.
And you can also use tenovicryl as another good solution, interrupted, if you don't want to take a suture out afterwards.
But can I also say, with the glue, the patients really enjoy it because, unfortunately, if they're uninsured, it's about $550 out of pocket. But if they're insured, it'll be covered by the health fund. But they are a lot more comfortable than sutures because it's not as inflammatory.
There we go. It sounds like a topic for a debate. Okay. So we have another question about a digital map comparison over time as a measure of progression, such as Presagio topography service, because all maps vary test to test, making judgment of progression exact. I mean, that's the whole problem with this judgment progression. We do not yet have a gold standard. If you have, and that's why, yes, you can use progression maps and different progression formula can compare between. But I think it's good to have some also parameters in your head just for checking off as well, to make sure that the data you're getting is reliable, because with scanning and keratoconus, it can be quite unreliable. So that's why it's good, if you're still using those maps, to still, have a look, is there a Doppler difference in either the topography, is the vision gone down, is there steepening? Any comments from the, we've got a few questions here, so let's go to.
Can I ask a question? So what do you do with the late 20, early 30-year-old who you followed for a few years and they've progressed very slowly over 4 years? So they haven't had the one diopter progression that you need in 1 year to say definite progression. Do you keep observing those, or do you cross-link them?
Look, if they reach threshold, I would have a conversation with them about the risks and benefits of cross-linking. I'd also, ask them about the eye rubbing and allergies and, try to counsel them around that. I mean, I think if they're not eye rubbing, there's less chance of it progressing, but it still can progress. So, yeah, I would talk about cross-linking. So now we're over to Fuchs. So what percentage of patients with Fuchs can actually have this DSO? And, how do you assess the peripheral cornea is okay?
So the assessment of the clarity of the peripheral cornea is done clinically at the slit lamp. So the only reason why I'm sending them for confocal microscopy is to physically get a count in the superior nasal, temporal, and inferior aspects of the cornea where it is clear. It's not really an assessment of the quality of the tissue because I've done that clinically already, but I want to know that the counts are over 1,000. So if I've got 3 of the 4 quadrants that are already under 1,000, I'm more likely to say to the patient that probably, we can have a go, but there's a high chance that this will fail and we'll still end up for a transplant. And some patients, I'll even book them a position on the transplant list anyway. And if they don't need to use it, then I'll bump that tissue to someone else. So it's really important to stress that's a clinical diagnosis, and not everyone has access to confocal microscopy. So there will be a certain subset or a large subset of surgeons in Australia who will be doing this purely clinically, and that is not a bad thing. It just means that you need to be really honest about your patients, that you don't have any numerical data about what their reserve supply is in the periphery. And so they just need to be prepared that you both need to go into this with both eyes open. In terms of the effect of stripping diameter on DSO outcomes, so 4 millimeters in diameter seems to be the sweet spot. When we looked at getting to 5 or 6, there is a tendency of patients to either recover extremely slowly or not recover at all. And so we don't really tend to go more than 4. So we mark that very carefully at when we're doing the surgical operation, and we're just making sure that when we're doing the desmetorexes, it doesn't go beyond that. What percentage of DSEC patients need rebubbling?
Yeah, so I'm just going to stick to this.
Sorry.
Just going to stick on this topic and just get some thoughts from Elaine about how easy is it to find these patients that are suitable for this DSO?
We're running a trial in Melbourne at the moment at Ionia Hospital. It is quite tricky because we do have quite a stringent criteria at the moment. I think, definitely, not wasting the patient's time, knowing that they have sufficient endothelial cells peripherally would be very important. So in case you can't have easy access to a confocal, SPECT microscopy will also show you. So they just need to make sure that they look down and left and right to make sure they have enough cell counts. And then there's another whole other topic about Rapazidil as well, and eye drops and stuff like that. So
Himal, practically speaking, like how long does it take for patients to sort of complete these, patient-reported outcome questionnaires such as the core?
Very good question. I think because when it comes to questionnaire, like people, clinicians usually think that it takes a lot of time, but actually we in our study we found that it takes less than a minute to complete the keratoconus outcomes research questionnaire.
That's good. Thank you. And so, yes, DSAC, what percentage of patients should need rebubbling? Let's get an answer from each of the panel members.
Ideally, none. No one likes rebubbling. In my hands, I only use DSEC for eyes that are complicated. So naturally, these rebubbling rates are going to be a bit higher. These patients will usually have an exit of gas within the first 24 hours. A gas bubble often ends up very small. It can even happen in the first 2 hours after the surgery, which is why the post 2-hour check is so important, not only for pressure, but also to see the size of your air bubble and see if your graft is attached. So the studies will quote probably up as high as 30%, but we are more and more reserving DSECs for complicated eyes, so the data is going to be a little bit skewed that way.
Elaine, any comments?
So I guess it also depends on which institution and what technique you use. So where I train in Singapore, the actual rebubble rate is actually, or dehiscence rate is about 2%. But, at the Ionia Hospital, when it's a training hospital and actual fellows are doing it, and it's also quite complicated cases, then it varies between about 5 to 10%, I would say.
Yeah, that's very true. Richard, any comments on it?
Similar. My rebubble rate, of course, was higher during the learning curve.
Yeah.
But when I became more used to it, it went to 0 for a year or two, and then people started referring me tubes and trabeculectomies, and of course the bubble of air disappears up the tube, or you can see it in the trabeculectomy bleb the next day, and you wonder why the graph's floating around in the AC. So more complex patients, are more likely to be needing rebubbling.
Yeah, sometimes after 2 hours, you sit them out, there's no bubble there.
And with these patients, sometimes I find, look, if it does come off, the graft can actually sit there for a period of time. And particularly if you've had an eye with leaky wounds, it's, I find sometimes going back like a week or so later is actually better because the wounds have sealed a bit. Because I think the main reason these grafts come off is because you lose your air, and they might rub their eye, you might get a small leak. So making all the wounds watertight, I've found reduces the risk of the graft coming off. And if the wounds are really hard to seal, waiting a week before you go back. Okay, so we have a question on pigmented lesions. How often do you remove them, Richard, for cosmesis?
Rarely. I tend to talk patients out of it because in removing it, you can create a scar and also redness. So, although that's uncommon. So, unless they're really, really keen, and it's it's a black lesion in the palpable fissure, and they're getting married in a few months' time, then I'll tend to encourage them not to have it removed for cosmetic reasons.
Okay.
So rarely.
Oh yes, go.
So Richard, how do you take photos? Let's say, in a normal practice, we don't have slit lamp cameras. How do you advise the patient, and how would you do it? Like, would you get the patient to take their own photos and put it on their phone, or what do you do?
Yeah, well, I have a slit lamp camera in both practices I work in, so it's The phones are very good these days, actually. The camera phones are very good, and you can get attachments to the slit lamp, use your own phone, get the consent from the patient, and somehow put it in their record. Or you can get them to take their own photo and keep it, as long as they keep it. But they are very good for comparing one to the other, the photograph. I would encourage that. Before photography, which I remember, you used to have to draw a very detailed picture and have measurements. But now the phone makes that so much easier.
Thank you. This is a question on filamentary keratitis. Look, acetylcysteine is available through compounding pharmacies. There was a period where the compounding pharmacies were having difficulties during COVID, but they're now operating and it is available. I don't think there's any restrictions on getting it. The only thing I'd say with filamentary keratitis is sometimes too viscous lubricants actually exacerbate the condition. So it may be that you want to really cut down on them or go to things that are less thick, and sometimes I've even just used normal saline. You may need some steroids as well. Any comments on that before we close?
Yeah, I've found that often there's mildly clinical or subclinical ocular surface inflammation with filamentary keratitis, and if you use a little bit of steroid for a short bit of time, it tends to help get rid of them.
Yeah.
And you don't need the stinging acetylcysteine, which does sting.
Yeah, no, I usually will go steroids first before acetylcysteine because it's expensive. They've got to get it from a pharmacy.
And it smells.
And
it
smells.
stings. and it stings.
Yeah, and steroids are generally good for a lot of things. Well, thank you, everybody, for attending the session. And we'll let you go and get some ice cream. I heard there's some in the exhibit hall if there's any left. Thank you.
Rum and raisin.
And I'd like to thank the speakers. Yeah, rum and raisin.